So the best thing about organizing this conference for me has been getting to invite people that I admire and who I look up to in the field, that have made me smarter, that have made me better as a person that works in this space. So I'm super excited for this panel. That description applies to each of our panelists, and I think you're in for a real treat. The people that are hardcore and still here at 3:50 on the second day of the conference. So you all are my people as well. So if each of you could tell us a little bit about yourself and your role and what got you working with addiction and recovery. And you are welcome to share different stories than you shared earlier, or whatever you want to do.
Yeah, not to kind of rehash what I went through earlier, but I moved to a community where this was really a space that was needed. So I actually kind of filled into that role. And I was really lucky to work for an organization that supported my continuing education and allowed me to kind of get skills and develop in substance use disorder treatment. I started it just a little bit, like dipped my foot into it, and I really enjoyed it over time. It's a young cohort of patients, typically, that have a lot to gain from services. And at the time, there was only a few physicians in my community that were providing this care, and most of them were the classic kind of MAT model where you came to your appointment and you had to provide your urine drug screen, and then you got your medicine and left. And really, it was very flat in terms of how people were cared for. And so one thing that we started, I'm a primary care doctor first, addiction medicine doctor second, is like integrating care of other conditions, so preventive care, kind of looking at the person from a global perspective. And when you start kind of shaking up the community and treating things a little differently, business was pretty good. Not that I was looking for business, but I got a lot of people coming in. And as time has gone on, I've just gotten more and more of this community. I find it very flattering that many people in recovery or the recovery support in my community have chosen me as their PCP. So it's flattering, and it's a great group of people to work with. So I've really enjoyed it.
Hi, everyone. Happy to be here. So I'm an academic, really, but before I was an academic, I entered into recovery. So in my first year, I started my recovery journey. Actually, that's not true. I started my academic journey while I was incarcerated. I got my GED while incarcerated, and that was my first foray into school after dropping out of high school due to full-blown alcoholism, substance use disorder at an early age. And I moved through community college, undergrad, university, master's, PhD, both in places that didn't have any sort of recovery support, and then at Michigan, University of Michigan, they had student recovery supports in place, and it really made a huge difference in my life in terms of being able to support women and see some of the inequities and some of the problems that were arising for students who were either in a MAT pathway or an alternative pathway and were trying
Recording in progress.
to be forced. Oops. All right. They were being forced to go into 12-step spaces and didn't feel like they fit in 12-step spaces, and that was my pathway. And so I really started seeing some problems with the program that I love, and really gave me a second chance. I just celebrated 20 years in recovery on Monday, so double decades. And it's been really my academic work to look at what are all the pathways, because from an insider perspective, someone in 12-step spaces, really that way is the way. And I became very interested in perspectives that didn't look at 12 steps. So what other ways are people getting sober? And tomorrow I'll be talking about Buddhist recovery pathways, which is one way that I've looked at and explored. But also exploring many of the other programs that exist, and the common thread that I've found in all of them, literally every single one that I've looked at, including ones in different countries and places you wouldn't think there was, addiction or existing recovery supports. It was all connection, right? So I really resonate with Johan Hari, who said, the opposite of recovery isn't sobriety, it's connection, right? And so I'm an academic, but I'm also the co-director of the Center for Addiction Recovery Support. So we are a newly funded technical assistance and training center, Office of Recovery at SAMHSA, which is lovely and also going through quite a bit right now, given the current climate. But really, my role at that center came after serving as a steering committee member at the previous iteration of it, the Peer Recovery Center of Excellence. And I got involved in that center because I recognized that the work I was doing on the ground and in the community, not as a researcher, but in my personal life, I felt like I wanted to expand. I wanted to do more. I wanted to reach more people. And I had the opportunity to work on that steering committee and then advanced into this new role. And so we provide technical assistance and training across a ton of different areas, including peer certification, peer supervision, recovery housing, justice involved, digital recovery support services, recovery-ready workplaces, all of it. And I'll talk a bit more about that tomorrow. But I think generally it's just really important that people know that there are a lot of different pathways and that there's a lot of support, and that we center the voices of folks who have lived experience. And that's one of our questions, so I'll stop there and not get into it now. Thanks.
Hi, everyone. Okay, it's working. Hi, everyone. As you do an introduction, you heard my name is Alethea Lambert, and the reason that I'm here is honestly because I hated food service. I hated food service, and I wanted something different. And so I also wanted to work for the organization that gave me a voice, because I am a drug court graduate. I graduated in 2007 from the drug court treatment program, now identified as recovery courts. And it was under the public behavioral health system, actually Hampton-Newport News Community Services Board. And I so badly wanted to work for the organization that gave me a voice. And things aligned themselves, and I was able to go and work for this organization as an intern. And in turn, I became a part-time employee and was asked if I wanted to take the peer recovery specialist training. And I was like, absolutely. Absolutely. And I drove an hour and a half each way for 16 weeks to take that training. And in that training, I was really blown away that individuals outside of the 12-step, my 12-step pathway, were happy, joyous, and free. I was like, what? That happens? And so something about that training changed the way that I saw mental health services, changed the way that I saw substance use services, changed the way that I saw recovery, and I wanted to be a part of it. And so, yeah, I kind of dug my heels in. I never saw me getting to this place, but you know, thank God that there is a God, and it's not me. And so being a part of the Office of Recovery Services has given me an opportunity to see not just recovery supports from a personal perspective or from a program perspective, or not even from just an agency perspective, but from a statewide lens. And I get to peek into the national lens as well. And so that has been just, it's caused the level, that connection that you were talking about across the system. And it has helped me to be able to see that some of the things that we struggle with in Virginia, we're struggling with nationwide. And so we are not alone, and we're all in this work together, so. Mm-hmm.
Hi, I'm Nicole. I am a clinical psychology PhD student at VCU. I'm also a person in recovery. I have 10 years. Thank you. Yeah, I like how you phrase like your reason, like what's my reason? And I think for me, the only thing I've ever loved as much as I love drugs is recovery. And so first of all, to give what was given to me to other people is like a blessing beyond blessings. And I just think like, you know, it gives me that motivation, that personal piece that like allows me to continue in a field where we face a lot of defeats and a lot of sadness, right? It gives me that hope. Yeah, and in my role more professionally, I'll say I get to do research about substance use disorder, so, you know, adapting treatments for people with opioid use disorder, looking at peer recovery specialists in tandem with doula support to improve maternal health outcomes, but I also get to, work with people as a therapist, and that really kind of feeds my soul too. So I'm really happy to be here.
Before you ask your first question, Tom, I wanted to add that I am a person in long-term recovery, and on Sunday I celebrated 20 years.
Yeah.
I know. You can't make this stuff up.
Right. This week 20 years ago, the world got a lot safer. Okay. All right. So one of the things that's always been both refreshing, inspiring, and super helpful to me as a professional is hearing from really smart, accomplished people about how their views have evolved and changed, and how, kind of that story of like, it's important that we give each other permission to change. Somebody said to me, your knowledge of medications for opioid use disorder is inversely proportionate to your passion for the topic. When I was early in recovery, right? That I had a lot of passion and almost no knowledge, and a lot of opinions that, anyway. So I'll put that out for you all, whoever wants to pick that up first. But how has your view of addiction evolved over the course of your career, and kind of what's been important in that?
I'll start, since I kind of talked a little bit about some of that evolution from my personal experience. And so initially, when I was introduced to the recovery process, it was kind of drilled in me that abstinence, abstinence, abstinence. And if I wanted to have successful and ongoing recovery, then abstinence was the pathway. And over time, I have come to understand, believe, and support individuals in identifying what works best for them. And so I've come to had to be educated. Let me say that. I had to be educated on medication-assisted recovery supports. I had to be educated on how that medication supports individuals to be able to take care of their families and go to work and do some of the things that I take for granted without medications. And I've come to have a better and richer understanding around harm reduction and the different pathways of recovery that don't include a higher power or 12 steps or a sponsor, in some of those pathways. And I'm continuing my education on how substance use and the treatment and services for that, for the disorder continues to evolve, and so one of the things that is related that I'm learning about is problem gambling, and how that affects the brain in some of the same way that substance addiction does. And so, so I'm continuing to evolve my understanding. You want to go next?
Sure. I think when I first understood addiction, I kind of might get a little weird here. I think I felt it was like a weed that I had to root out, right? Like I needed to eradicate it, get rid of it. It was bad. And right now I kind of think, I've heard in recovery spaces like recovery is like a garden, but I think addiction and recovery are really the same garden. And in a garden with addiction, maybe it's not getting enough sunlight or the soil chemistry is wrong, but we have tools to kind of fix those things, right? So whether it's like, okay, the soil chemistry is wrong. All right, let's talk about buprenorphine, or maybe we need to work through some trauma. So I kind of think about it from this place of like, instead of addiction being this, I don't know, this bad, this evil thing, it's really in some ways like the root of so much of my strengths and so many of our strengths, and that really, it just makes me thankful for it in a way that I can see in my patients, and it humanizes them and it humanizes the experience, and it also just gives me hope that even in these places where it seems like things aren't growing, we can like work on that and make them the way that we are. So instead of seeing it as this thing to root out, I see it as something where something's already growing and we just have to kind of work to make it bloom a little bit better.
So I did talk a little bit about this in my intro, but I think the first experience that I had that really opened my eyes to seeing different ways of approaching recovery was while I was in India. I was doing a global learning seminar, and I was sitting in on some teachings by the Dalai Lama, and it was 5 days of sitting with monks and nuns, and it was being translated, and the parallels between my recovery program that I had got sober in and what he was talking about were undeniable. Like, I mean, I had a whole notebook that I just took notes on linking it all together. It was really the catalyst for some of the work that I've done. But it was the first time that I saw, like, okay, these principles might be universal. There might be something to it, and like, what else is possible, And so initially it was really like, this is the way, because that's what I was taught. And from my, I was a pretty low bottom user, alcohol addicted person, and my story includes incarceration. And so for me, anything that suggested that there might be a different way aside from 12-step, I viewed it as like personally threatening, right? Like, it threatened whether I was going to stay or not. And I was told very clearly, like, you will die if you leave, right? And so, I even have one of my very best girlfriends, she made a decision to leave 12-step. And I remember when she told me, I was so angry and I started crying because I wanted to leave. And then I thought she was going to die, right? Like, so there was a lot hidden in those, that early belief system. And over the years, 20 years now, I've really grappled with and come to terms with, there are many pathways. All of them involve connection. I've met people who have been sober for decades who used physical activity by joining gyms and connecting with people. I mean, the Phoenix is a pretty powerful example of that, right? I mean, they do other things as well, but there's connection everywhere. And so really for me, it's been a shift of like, there's this one way and that's the pathway. And it felt to me like the only way really when I was coming in 20 years ago. And now there are a lot of different ways to meet people where they are, and tools for people to use. And so I'm on the board of She Recovers, and I love the way that which is an online resource community group for women and female identifying people, recovery support. They describe it as a patchwork approach, right? So we're our best expert on what will work for us, and we know what we need. I mean, provided our minds are clear enough to know that. And so really take what works and take what resonates with you and use those tools. And so there's been a really big shift, and my hope is to get that message out and to help more people, right? Because people are dying, right? This one-size-fits-all approach doesn't work. And I've seen people try to be forced into 12-step, and it doesn't resonate for folks. And I've seen people die because of that, right? So I'm in the business of saving lives. I want to help people, and so that's my mission.
I think my view of kind of addiction has really evolved over the years, mostly based upon this idea that abstinence only is the only outcome that matters. So I'm not in recovery, so I kind of lean on to other people a lot to give me information about this. And early on, I partnered with an abstinence-only program and peer support. And people doing marijuana or things that are kind of not really putting their life in jeopardy were dismissed from the program. And I'll be honest with you, 8 years later, I'm kind of ashamed of that. It wasn't something I'm proud of. I look back and I didn't make a good choice there, right? I should have continued to work with that person. And I feel like I just didn't know any better. And I work both in the office, but also the hospital. So I do consults there. And sometimes, I'm not even trying to get someone into treatment. Sometimes the goal is just to keep them in the hospital to treat something that's killing them, because they want to walk out the door and shoot up fentanyl, and they don't want to treat their endocarditis. And that's okay. And the idea is that they can come back and see me, and that they feel welcome to come back and see me. And it might be the second or third time they come to see me that they actually go more into an abstinence type treatment program, or they kind of do a more harm reduction program. But this is a long-term game in primary care. I want them to come back.
So I'm so glad, and this is a little aside, but I'm so glad you named that kind of shame, because I think for folks that work in this space, if we engage with professional education, because most of us were pretty poorly prepared to work with this topic, whether we're in recovery or not, we all kind of made mistakes, many of which could have had really big consequences for people in their lives. And kind of holding that shame, I think, is a really, really common experience for people that are really engaged in kind of understanding what's really working for folks. And I think that's a real connection we have, whether or not we're in recovery or not, for folks that work in this field, is we deal with a lot of the legacies of not being good enough at helping people get well from substance use disorders. So actually gonna skip a question. I might come back to the other question because it's really in line with this. And there's a fabulous quote, terrible, but a little bit, I don't know, I think it's great, from Bill White, and is a recovery historian. And he has this quote around, he was doing some research and he came across this article that this physician was having tremendous success treating opioid use disorder by prescribing cocaine by the kilogram. And he had found that his patients had totally lost their appetite for opioids and were coming back for further prescriptions of cocaine. And when I work with students and student groups, students like counseling students and that sort of thing, I bring up that story because it's more than 100 years ago. But I also, connected to what was shared, is we as professionals always have to be thinking, like, what in 10, 15, 20 years are we going to look back on at our practices and say, what the hell were we thinking, right? And so that's kind of my next questions for you all is what's the current really common practice that we have in our different roles that it may not be something we're currently doing, but is a common practice across the space that we think, oh, I'm going to look back on this in 15 years and say, what the heck was I thinking? Or what were people thinking that will just not be a practice anymore?
I think, well, I feel like it'll also be good, right? Like, it's like good in 15 years if we look back and we're like, oh, we figured something out here. Right. We made progress. We learned something. And I'm not saying it's good that people right now aren't getting the best care, but I think it's good that, like, we're going to learn lessons, and there's something positive about that. I guess the thing that, like, pops into my mind most obviously is the fact that we kind of spend pennies to the dollar, like if you look at, like, prison and jails compared to treatment. And so that seems like such an obvious, what are we doing, and why are we setting up this structure of punishment versus prevention and treatment? So yeah, I'm gonna stop with that.
Yeah.
I agree with you that we're gonna look back and think, what were we thinking? Like using jails as our settings for treatment, and that revolving door, as opposed to finding out the root of the cause and providing support and treatment for that. I would say that, and I think this is a safe space, that 15 years, we might look back at the legalization of marijuana and wonder, what were we thinking? What were we thinking? And we talked a little bit about this, that cookie cutter approach that, you come into a treatment services, and as opposed to meeting the individual where they are and finding out what, allowing them to be the expert on them as we, navigate and support them in understanding the disease of addiction, how it impacts your life and your thinking and all of that, we just kind of apply on a cookie cutter approach, okay? And that 12-step recovery isn't the end all, the be all for everyone. Being able to look back and realize that we should have moved away from that much earlier than we have. And then I'm just because I had some notes here because I know I need to make notes. And so the other thing that I have not said is, in 15 years, I think we're going to look back and wonder why has it taken us so long to have a standardized methodology for tracking recovery outcomes across the system. There is so much tremendous work being done across the system, and there are only siloed ways to talk about the work that's being done, how we are impacting individuals' lives, communities, families, and I know that there is a national discussion going on developing core outcome measures for recovery. And so I think we're going to look back and think, oh, was it that simple? Could we have done that and be in a much better place to have told the history of how recovery has impacted our nation?
I want to say, like, the number one, I think that we're going to look back and be like, what were we thinking, is treating illicit substances with other illicit substances. I'm going to start first with marijuana, and I might get hit with a rock walking out of the room here. But the data regarding medical marijuana is awful. So the only conditions that there's any indication or evidence that it actually is helpful is pediatric epilepsy, neuropathic pain, and cancer-related weight loss, not 18-year-olds with back pain. And unfortunately, we're seeing more and more of this, and then we're seeing states that have legalized at an increasing rate of health-related complications from chronic marijuana use. We know that using marijuana before your brain stops developing is harmful for your brain. You have a lower IQ, you have higher rates of schizophrenia and bipolar disorder, and your brain stops developing in its late 20s, right? So it's not a 15 or 16-year-old. And then kind of even want to talk about the social component of that, it's an incredibly racist-based system. So medical marijuana dispensaries favor white upper-class people that own those dispensaries. They take money from people. And then people of color don't have the $200 fee to go to the guy in a Hawaiian shirt to verify their medical marijuana every year, right? It's something that it's just such a bugaboo to me. I honestly think it should probably be legal, and we should accept it for the socially acceptable vice that it is, which is kind of what it is, and we can start having a real conversation about it. The second is psilocybin, so hallucinogenics. There's a big push for this right now. Now, there is some minimal data about this, although it's not what people think it is. I have young people coming to my office doing hallucinogens, thinking that that's a treatment outcome. And actually, the one study about this is paired with intensive counseling. And actually, most of the gains for smoking cessation occurred prior to introduction of psilocybin into the treatment arm. So it's not this be-all, end-all. And I think that deregulating that and having like widespread hallucinogen use and kind of acting like this is medical is not going to be in our best interest.
So I think one of the things that stands out that hasn't already been said, because y'all have said some good stuff, is this idea that when people clearly need help, but they're not ready, right? They're not ready. They didn't get it because they're not ready. And you know, I think of myself as someone that went through mandated treatment, really, because I was, you know, facing a pretty heavy jail sentence on top of what I had already done, prison sentence, really. And there wasn't a recovery court or a drug court where I was in the system that I was involved in, but the judge sort of created one. And so there were all these stipulations that I had to do. And you know, what happened is, at the time, I didn't think I needed help. I didn't think I was capable of being sober. I had no desire in it, I had no interest in it, but I did not want to go back to jail. I didn't. I knew that. And so my plan, my master plan, this is 24-year-old me, was I'm just gonna do this stuff, and when I get off, I'm going back to cutting and running and living the life I wanna live, right? And by the time I hit the end of that term, which was 18 months, it actually wasn't the full term because I did so well, I had seen what real friendship, real connection is. I had a bit more stability. I learned how to regulate emotions. Life was a lot different, and I didn't go back, you know? And so, you know, I hear that a lot, and maybe it's just that I'm a bit biased because I'm in some 12-step spaces predominantly in my personal recovery. We hear they're not ready, you know, and I really feel like I don't know what the answer is to that. I know that Canada has some interesting solutions, highly controversial. In fact, Alberta, our province of Alberta, just started having real discussions and implementing mandated treatment Not a one-size-fits-all approach, but interesting assessment and then treatment mandated. So there's other ways to do things, and I'm not saying that's the one, but what I don't like is seeing someone die who, the idea in recovery spaces was that, well, they're not ready yet, right? I wouldn't have been ready. I would have been considered as someone that's not ready had I not had those really intense consequences looming over me. So I think and I hope that in 15 years that's not going to be such a predominant theme. And then I think you already touched base on the abstinence requirement and this dichotomous, like, did they use, did they not use, and then that being the basis for housing and for shelters and for, really interested in broadening the scope of the outcomes and measurement tools that will help assess that. So hopefully we'll see some progress there.
Yeah, that's awesome. So maybe we can start with you on this, Onawa. What advances in addiction treatment and recovery support are you most excited about?
I will definitely talk about that.
Yeah.
I am most excited about the recent push that I've seen in the past few years for folks with lived experience, whether that be peer recovery support specialists or people, put in leadership positions on grants and at centers, really centering, not just having folks with lived experience as an advisory panel or, on the periphery, but really centering the voice and the expertise and the knowledge and the practical lived experience in the work, right? And my partner and I, Annie Powell from One World Recovery Network, she's the director of the center. She's a person with lived experience, Black woman, strong, amazing. I'm Indigenous, both of us with lived experience. And SAMHSA funded this center $10 million over 5 years to lead technical assistance and training for peer recovery support services across all those areas. And it's the first time they've done that. And whether or not we'll still be funded is yet to be determined, but it's an aside. I think we will. I'm seeing it in a lot of places, and I'd like to see more of it. I'm really excited about it, about the progress, about I oversee the research-based evidence arm of our project, our program, and evaluation, and I very quickly added evidence-based practice to that, right? Which research-based evidence is, what does the research say, and what's the evidence coming out of the research, which is fine, but what do the people that are doing the work say, right? What is the practice? The folks that are in the trenches, that are on the ground, that are doing the work, right? You give them a problem and you ask how they're solving it, and they're gonna have some really creative, relevant solutions, right? There's a massive disconnect between the evidence from, RCTs or randomized controlled trials and very academic studies and what's actually being implemented and what's working. And so I'm hoping to bridge the gap. I'm really excited about that.
So a few of the things that excite me are the fact that terms like harm reduction and needle exchange are no longer frowned upon. Like, we welcome that type of talk and celebrate it because we know that folks are saving lives, and we are doing our best to ensure that some of the communicable diseases that go along with addiction are mediated. And so another thing that I think is exciting is the introduction of Recovery Corps into Virginia's workforce and ensuring that peer support is accessible for non-traditional settings, as well as organizations who may not have the funding to employ, the evidence-based service of peer supports. And so I think that is a much needed program here in Virginia. I would also say another thing that I'm excited about is that DLC has opened their doors for peer supports. And what I mean by that, and that excites me, is that they are interested in developing their own PRS, trainer of the trainers, inside of the system, so that individuals can actually receive peer support and create a pathway that organizations do not have to come from the outside, but they can grow, this much needed workforce within within the walls. I am excited that medication assisted MOUD is welcome in jails when they didn't used to be. If you needed medication, then you either, were cold turkey or, put in isolation and, with no support, no help, no assistance. And so I'm real grateful that we have moved to a system now where the understanding of the need for medication is prevalent across the system. And having reentry services and coordination for individuals exiting the correctional facilities, having reentry that includes housing and vocational and educational support and all of those items. And we're not just thrown out into the streets with no services, no wraparound services, no connection to mental health services or substance use services. So those are a few of the things that I am excited about, and all of those things lead to decreased overdoses and an increased connection with families and dreams and goals once again. And so people are able to have a shot, just a shot at having their dreams restored, that hope, having that glimmer of hope and within reach again.
Yeah, I feel like so much has been said that was wonderful. I don't have many original thoughts on this question except to say it's the saying, it's if you only have a hammer, everything's a nail. I feel like addiction treatment was like that for a long time. Abstinence, abstinence, abstinence. And what's amazing to me is also I think we're moving to this place in treatment where people in abstinence programs, I find us to be sometimes the loudest champions of harm reduction. And I don't know if that there is some tension. I've seen it, I've heard it, I've gone to enough meetings to hear those meetings that hate medicine or whatever. But I think that a lot of that narrative is not quite true also. I think there's a lot of us doing a lot of different kinds of work, and I think recognizing that and talking about that, we can do more of that. And I also think maybe this is just because we just have been talking about this, but the peer, and it's not even my field, but thinking about peer recovery support, becoming its own degree, becoming its own field of study, that is so exciting because mutual aid, it saved my life. It saved so many people's lives, and giving credit to the people who have the generations of people who got clean before me that kind of allowed for this to be possible. And carrying on that legacy is it makes me feel so excited about what's to come.
From a medicine standpoint, I think the two things I'm most excited about is one, semaglutide, so that's Ozempic or Wegovy, the weight loss medicine that all the movie stars are taking. That looks very promising for alcohol use disorder and possibly tobacco use disorder, and it actually just passed phase 2 of the FDA. So I think that is going to optimistically be our next drug in the toolbox for alcohol use disorder. Some of us are already using it off-label since it has an indication for pretty much anything under the sun, but it's expensive for approval, so it's going to be here soon. The second one I think is going to be methadone deregulation. I think currently access is quite an issue there. I don't know if it makes you mad, but it kind of makes me mad that if you came to my office and you sprained your ankle, I could give you a course of methadone for your ankle. There's no problem with that. I could prescribe that to you and no one would bat an eye. But if you had a problem with your methadone supply from your OTP, it got shut down, I can't give you a 7-day bridge script to stabilize you until we get you into another treatment. That's wrong. And so I'm hoping that we get some leverage here that, we're going to have some guardrails for safety. Methadone has a riskier safety profile than buprenorphine, which is for the most part relatively idiot proof. It kind of saves itself. It has a max effect, so you're not going to overdose if that's all you're taking. But I think that it needs to be more accessible than just an OTP.
Okay. I love all of that. Just a lot of wisdom in this space. So I'm going to skip to this one because I'm really curious about how specifically in each of your practices or kind of each of your roles, the changing drug supply, the drug supply has changed dramatically over the last 2 decades. And so kind of how have your practice or how's that affected and how have you adapted to that? And I think paired with that is, what strategies do you use to keep up to date with the kind of changes both in substance use and the regulations connected to substance use? So maybe one practice and, one way you've adapted services.
It's way harder now. Like, fentanyl it's no longer heroin. We're dealing with fentanyl. I don't even test for it anymore. I just know it's fentanyl in the current drug supply, and it's a whole different animal. Couple things. One is it's super short acting. So if you have risk from injecting drugs once or twice per day, now you're doing 6 or 7 injections. You're multiplying your risk. It's fat soluble like THC, so it builds up in your lipocytes and so in the adipocytes so that it leaches for weeks afterwards. So it makes precipitated withdrawal a real problem for us when we're kind of inducing someone in the outpatient setting. And also, it looks like we have to use higher doses of our currently existing drugs to kind of capture symptoms of withdrawal. So it has made everything a little more difficult for us. The one thing that I know we've kind of changed is kind of the low dose inductions where we're giving kind of like these sub 1 or half milligram doses of buprenorphine at lower doses over a longer period of time to try to catch the receptors as the fentanyl displaces, but it's really made it very difficult for us.
So for my office, it's always peer support and utilizing the lived experience workforce as boots on the ground. And what I mean by that is engaging with individuals to kind of learn what's out there and utilizing services like comprehensive harm reduction, where the individuals, you utilize peer support and gain that connection. And I know that I was out with Chris Atwood Foundation on a harm reduction site, and and when they are engaging with the individuals that they serve, they're able to learn, what are the new drugs, how are they utilizing the new drugs, what are some of the side effects of those new drugs, and what are some of the street names for those new drugs, so that when we're out and we hear some of that information, we have an understanding of what it is that we're hearing, what it is that we're talking about, and how to combat that. And then we can, connect with our clinical partners and get educated and trained on how to best serve and provide support for these individuals. I would say another thing that we're excited about is being able to train our workforce to identify and overdoses and utilize Narcan, as well as provide test strips and some of the other apparatuses and tools that we need to have safe usage and prevent the spread of diseases and combat substance use.
Good.
Yeah, couldn't tell. Okay, wait, what question were we on? Sorry, I got really into your answer. I lost it.
Change in drug supply.
Oh, the change in drug supply. Okay, yeah. Well, in therapy, it's interesting because, we have all these studies that are like, yeah, cognitive behavior therapy works, contingency management works, all these things work, but why do they work? And the mechanism that we've found that kind of helps all these things work is basically whether you like your therapist, right? It's whether you have a good relationship with that person. And that doesn't really change across drugs, but they have to, the person has to be alive to decide whether or not they want to get to therapy. So I'm not kind of in that frontline position, but in my position, I can still use the tools that I have, generally speaking, but it does change the questions I ask. Do you test your drugs? Are you using meth? Are you using drugs? It's like kind of informs that. And then I could get maybe nerdy and talk about wastewater testing, which is cool, and having a rapid response team. But I don't know very much about that, but I think probably it would be cool to fund that stuff so that we had a protocol in place. But I feel like the funding conversation right now is a tough one, but yeah.
So I'm also not on the front lines, but the people that we do work with at the center most certainly are. And so we have a steering committee from all over the United States and territories. And really their role is to go out into the community and talk about what technical assistance and training is, which is really just any sort of support to expand peer recovery support services. And so we have them go out into the community and then they come back to us, and we have conversations regularly about what's happening, what the landscape is, what the specific needs are in rural communities versus other places that people are at. And so a lot of my information comes from them, and then I think really the landscape changes so quickly that, again, the one-size-fits-all approach just doesn't work, right? Like, we need to be more agile. We need to have more options. And so I think that's one of the reasons why I'm personally really excited about peer recovery support services and the talk that was in this room. I think, not the last one, but the one before that, the gentleman was talking about integrating them into healthcare and the need. And that's one of the challenges that we've seen is actually the implementation of it, because it's fine to have peers in the workplace or to have an organization with peers, but if they're not recognized as the experts that they are and the implementation doesn't go smoothly and they're not given the opportunity to actually be colleagues in the process, right, then that's a problem, and then it's not going to work. It's not going to be anywhere nearly as effective, right? And so I think that they play a huge role in this.
Okay, and just about the last question, but I'll have a wrap-up question as well. Questions of, I think we sometimes don't talk enough, and I'm really glad you all in your talk talked about alcohol and nicotine. So alcohol, nicotine, and cannabis continue to be the most commonly used substances of addiction and have enormous societal health consequences, even as alcohol remains ubiquitous. Nicotine use has increased for the first time since the 1950s. And perception of harm of cannabis is at an all-time low. What are your thoughts about how we better address any of these substances as we move forward? And I think I'm going to ask you each to pick, you don't have to pick different substances, but maybe stick with one substance based kind of on our time. So pick your favorite.
So I'll jump in. And I don't have a favorite. I don't have a favorite, but I think just education, and training on the impact of substances across the board works for our lived and living experience workforce. I will say that ensuring that recovery is accessible across the system is going to be highly important, no matter what substances that we're talking about, or that's premiering as a trend. But having recovery community organizations and funding for peer providers at the local level is essential, so that individuals don't have to go through treatment in order to access recovery supports. That is essential, no matter what the substance of the trend may be. Having recovery-friendly workplace initiatives across the board is important, so that organizations will have policies in place to be able to identify and work with individuals who have substance use disorders. And I would like to add that ensuring that no matter where we are in the system, that there is nothing about us without us. And that nothing about us without us isn't just a slogan, but it's a framework. It's a framework for how we operate in the system. And so as long as our workforce is trained, and as long as addiction exists and recovery is prevalent, then we're always going to have a workforce that can that can be combative and supportive no matter what substance is prevalent. And we can tell you not only what the substance does, but what, some of the intricate needs of our individuals who are experiencing that's needed in order to transition into the recovery space. So, yeah.
Thank you. I'll just say quickly, I'll talk about nicotine, I guess. I think, I just feel like tobacco probably shouldn't be able to lobby or have, money in politics. I hope there's no Altria reps in the room, but, yeah. And also, I've heard this morning at the talk, that it's never too late to quit smoking. And I loved that takeaway so much, because sometimes it feels like it's so hard to quit smoking, right? It's so easy to think it's too late, but it's never too late. And I think that it's the thing that kills the most of us. That's the truth. And it's not as sexy to talk about, but it's the truth. And so, yeah, just keeping that in our minds.
I think kind of looking at those three substances, kind of one, alcohol's decreasing kind of in younger generation, 20 to 30 demographic. So it's legal. We know that it's decreasing. Nicotine has kind of transformed really from a combustible tobacco product more towards a vaping heavy predominance, which may be better. We don't know that, but it looks like there's a little bit of conversation that those are unhealthy. I think it's the cannabis one that really kind of rubs me the wrong way. We have this medical cannabis thing, which is really kind of a backdoor legalization. And I think that having honest discussions about what the true harms of cannabis are, it's not a natural product anymore. THC concentrations at baseline were 4%. Now they're 15 to 40%. They're genetically engineered strains. This is not the stuff that's growing in the backyard. So I think we have to be able to kind of understand that a little bit more. I also think taxing that, like we do alcohol and nicotine, to kind of account for how much that kind of burdens our healthcare systems is really important. And so I think that we need to treat that just like the other two vices and kind of treat it similarly in terms of our reduction of how much that's impacting our system.
Awesome. And I'm just going to build off of that with my personal soapbox issues to mention how ubiquitous alcohol is in our society and the kind of tax, lobbying, all of that. Jason, will you hold up that can of Polar? So this can of seltzer water has nutritional facts that it has nothing in it, right? It's 0%, it has serving size, it has all of that. If you go out and buy a beer, it doesn't have to have any of that stuff. It doesn't have to have any of that stuff. It doesn't have to have serving size, like how much alcohol, right? It's wild, right? Every food product that we buy has all of that crap on it, right? And all the alcohol that we buy, you go buy a fifth of liquor, right? It is not going to tell you how many servings are in that bottle. It is not going to tell you anything about, it has to say the alcohol content, but otherwise. And similar things, if you heard Dr. Peace's talk about how mislabeled our cannabis is and all of that, right? We have totally failed to make regulations that really value public health. And that's just a quick aside and soapbox for me.
It's the reason that the Federal Drug Administration and the Food and Drug Administration is under one roof.
So I actually have a question for you, John. From a medical standpoint, during your training, not anything that was specialized in terms of addiction, I'm curious to know how much time was spent on alcoholism, causes, conditions, treatment, anything like that. Little to none. Yeah.
I will say one thing real quick. I'm super optimistic about the future. And kind of here's why I say this. When I went through medical school, there was very limited to no treatment regarding substance use disorder. When I graduated residency, there was opportunities to expand, but it wasn't a core training curriculum. Any doctor, and I'm a medical educator too, so I train our residents, you cannot graduate from a primary care specialty, family medicine, or internal medicine without the competency of knowing medications for substance use disorder. It is now a core competency, so everyone has exposure to it.
That's really encouraging. I was speaking from the perspective of someone that's done service on professional committees where we were tasked with trying to convince nursing faculty and medical school faculty to let us in to have conversations about peer support and what that looks like in addiction and really tell some of our stories. And when I started digging into how much time is actually spent talking about these conditions and then knowing the sheer volume of health issues and accidents and domestic violence that are directly attributed to alcohol, it just seemed like what a huge missed opportunity to address a really, really expensive and harmful public health problem. And so, I'm not saying that doctors would fix everything, but I think having core competencies in what alcohol addiction looks like or overuse of alcohol, I think it would go a long way. That's my personal opinion.
All right, so we'll close out with a rapid fire. So just one thing from each of you, a quick change, not that we could do it quickly, but a quick response. One thing that as a state, country, or community that we could change that would move us towards making robust healing, right? Like beyond just survival and expectation of folks that have addiction.
Healthcare for everyone.
I'm a fan for that as well. Healthcare for everyone, and that peer support and recovery supports can be accessible through the community without having to, or in the public behavioral health system without having to go through a treatment program.
As a permanent resident of Canada, where we have health care for all and pay about 40% in taxes, I don't know that that's the solution. I mean, it seems like it would be, but anyways, I digress. I think more successful implementation of peer recovery support services. I do think that that's the future, and I think that there needs to be smoother implementation. There needs to be opportunities for expansion. There needs to be, it doesn't need to be just like a first stop on the way to doing an actual career. It needs let people have an actual career ladder within that structure, right? And pay them a livable wage. For the love of God, they're doing, incredible work. And so personal mission here. That's what I'm aiming to do. That's what we're trying to do. And we got a lot of people that are focused on that. And so, hopefully.
Yeah, I mean, you might think that as the doctor, I wouldn't advocate for this, but yeah, I think the idea of a universal payer makes sense. We're actually already paying for it. I'm in an MBA course right now, and we're actually already putting out the money that could easily fund a care for all system. We just choose not to. We allow an insurance industry to siphon off 10% of the operating costs of the healthcare industry. They're legally allowed to do that. That could be put into other resources. If we had a universal payer, we could negotiate drug prices to something reasonable, not these ridiculous drug prices of $1,400 a month for life-saving medications. There's no reason that some of these drugs should cost $1,000 a month, right? There's absolutely no reason for this, but we've lost the power to do that. So I do think that would at least allow everyone to have access. It shouldn't be a big push when someone gets private insurance after doing well in state insurance that they lose their treatment, right? That happens all the time with these depot medications. Like I don't know the current price, but it's like about $1,000 for the IM naltrexone, the Sublocade, which works, and then someone gets insurance and they're no longer allowed to have access to that. That's wrong. And it wastes a lot of healthcare dollars, right? Someone that's not, I have this discussion with our administration all the time about, they say like addiction doesn't make money, and that's kind of a general thought of the United States of how we treat this. But, actually people that are in addiction and they're not well treated, they actually use up a lot of resources. It's much more cost effective to treat them and engage them in their care. And we need to look at that instead of just this fee-for-service model.
Awesome. Well, I'm sorry you all didn't get to ask questions, but I had so many questions that I wanted to, and it was my panel, so I got mine answered.